Hey guys, sorry for the slight delay. I hope I'm audible to all of you. Good evening, everyone. So, welcome to this Read Harrison's with Dr. Patil or Dr. Santosh. I'm Dr. Santosh. I'm your faculty for medicine at PW Meded, and this is our tiny attempt at simplifying medicine and also concising the vast resource called Harrison's Medicine. Over the years, we have observed that students have started moving away from preparing medicine as a subject. It's like, okay, chhod dete hain, whatever we can answer, let's answer logically, and if there's something which we can't answer, let us give up. But medicine is the most crucial subject. You're not supposed to give up on medicine. And Harrison, जितना लगता है उतना vast और complex है भी नहीं. It's quite simple, easy to navigate through, and that's what I'm here, trying to make it easy and simple for you to navigate. If you're able to hear me loud and clear, just give me a thumbs up. Welcome all of you. Welcome all of you. Jashwant Kumar, the objective of this is to bring a complex topic from Harrison in a concise 2 or 3 page review. So if you're in second year, this will definitely help you on various grounds. Number one, it will help you to reconnect with physiology. This is one biggest mistake that most of the MBBS students do. Forget the physiology by the time they get into second year, and then again try to relearn it during the internship. हमको वैसे नहीं करना है. So if you are in touch with medicine, that also means that you will be in touch with physiology. And मेरा approach भी वही रहेगा. We will definitely touch physiology first, and then we will get into medicine. And by that time, you will realize that medicine is nothing but a refined version of physiology, trying to apply the principles for patient care. Second, if you're in second year or third year, definitely you're going through what is called as early clinical exposure from your CBME, and in that case, you will make better use of that time spent on early clinical exposure if you're in touch with medicine. And if you're in final year, this concise description of Harrison's topics will help you to write your final prof as well as step up your game of preparation for NEET PG or next. Okay, you're not able to hear me? Just give me 1 second, guys. Just give me 1 second. I'm able to hear you out. If you're not able to hear me, just give me a second. Just let me know here if I'm not audible to you guys. Okay, so I'm audible, right? Okay, good. So we'll begin our session called Read Harrison's with Dr. Santosh, and first session we're doing is cough. As we all know, cough is the most common complaint that we as physicians or respiratory physicians will see in patients with respiratory disorders. In fact, when we see patients with respiratory disorders, it is very difficult to localize where is the problem. If I have a patient with neurological disorder, I can easily localize where is the problem, whether it is in the brain, brainstem, spinal cord, peripheral nerve, neuromuscular junction or muscle. It is quite easy. But for most of the respiratory disorders, there are two standard complaints. One is cough, second one is shortness of breath. Until and unless we fine tune our understanding of these two symptoms, it is very difficult for us to diagnose the patients presenting with respiratory disorders. So we will begin with cough. Okay, so when it comes to cough, Harrison usually talks about what is cough. He talks about cough mechanism. Then third thing he talks about is an entity called as impaired cough. And then he will talk about how to approach a patient with cough. Eventually, he closes the discussion with certain discussion on the management. Same thing I will try to simplify going through my own approach. So what we will do is we will first define what is cough. We will understand the cough mechanism, important causes which you should remember, and then little bit about management. So first and the foremost question, what is cough? So right now here I have put a dictionary definition of cough which goes like this. Cough is an innate primitive reflex and acts as part of body's immune system to protect against foreign materials. This is the dictionary definition. What does that mean? It means cough is something which is a reflex, right? That is the first point to understand here. It is a reflex. Though we can voluntarily suppress or if you want we can voluntarily cough, most cases it comes as a reflex. Okay, now why do we have this reflex? Most of the reflexes are designed to protect us. Just to give you an example, while I'm talking to you, suddenly if I touch my hand on some hot pot here, like maybe my wife has given me a cup of coffee and I suddenly touch it, without even me thinking, I will promptly withdraw my hand from that hot pot subconsciously, right? This is what we call as a reflex. Reflexes are designed to protect us. So now this cough reflex is designed to protect our respiratory tract from foreign bodies as well as internally produced harmful substances. Clear? Okay, why do we cough? Mainly we cough to throw out the foreign bodies. Now there are two major mechanisms to throw out the foreign bodies. The first one is you have a ciliary belt, you know, that upper airway, and the trachea, bronchi up to terminal bronchiole is lined by an epithelium called as pseudo-stratified ciliated columnar epithelium. Which epithelium? Can anybody comment me? Repeat again after me. Which epithelium the conducting airway is lined by? So somewhere at the end, let me make some important note points. The conducting airway. See, now when you look at airway, airway has two parts. The first part we call it as conducting airway, which is lined by what we call as pseudo stratified ciliated columnar epithelium. Pseudo stratified ciliated columnar epithelium. Now this epithelium does not participate in the gas exchange. It cannot allow the diffusion of gases. So whatever air that is there in this is not participating in the gas exchange, and an important part of this is it is ciliated epithelium. So you have cilia which beats in one direction. Whatever tiny dust particles, viruses, fungi or small particles reach the airway, they will be cleared through this ciliary belt. But if ciliary belt gets overwhelmed, means particles, dust or substances which are larger in size or larger in quantity, which ciliary belt cannot handle, that is where we trigger the cough reflex. True, Heller and Manpreet think absolutely right. So where is the conducting airway located? From your nose to your, see, like, let me simplify the whole respiratory anatomy. Let us quickly revise it. So when we talk about the respiratory system, we have a upper respiratory system and we have lower respiratory system. So let me begin with one basic question. Where our upper respiratory system ends and where lower respiratory system starts? Naiman, where? Yes, I will share the notes and I hope my handwriting is good and legible for all of you to make sense out of it. Okay, so where the upper respiratory system ends and where the lower respiratory system begins? Rishabh, you will see, just spend 1 hour a day with medicine and spend more time with your basic sciences, second year subjects and first year subjects. You will crack medicine damn easily. Okay, so our upper respiratory system, we have upper respiratory system and we have the lower respiratory system. And as we know, the upper respiratory system begins with our nostrils or nose and ends with larynx. That is our upper respiratory system. And then from trachea to alveoli is our lower respiratory system. And within this trachea to alveoli, from trachea to terminal bronchiole. So we know that trachea divides into right and left bronchi, goes through several generations of division until we encounter terminal bronchiole. We call this as the conducting airway. We call it as conducting airway. Now this airway is lined by pseudo-stratified ciliated columnar epithelium, and because of that this cannot participate in gas exchange. This primarily acts as a conduit for passage of air from outer environment to the lungs, and whatever dust particles, foreign substances come through it, with the help of ciliary belt it will be able to push back towards the upper airway. And then we have this respiratory bronchioles which lead to the next component in the airway is the alveolar duct, and then next these alveolar ducts lead to alveoli or alveolar sacs. Alveolar sacs. And this part is what we call as the alveolar airway. We call this part as alveolar airway. This airway is lined by simple simple squamous epithelium. It is lined by simple squamous epithelium. And because it is lined by simple squamous epithelium, this can participate in the gas exchange. So this is one repeatedly asked basic physiology question, right? Where all gas exchange can happen. Gas exchange can happen in respiratory bronchiole, it can happen in alveolar ducts, and it can happen in the alveoli or alveolar sacs. And this is what we call as the alveolar airway. You can also call it as gas exchange airway, and one respiratory bronchiole, all concerned alveolar ducts and all concerned alveolar sacs together, we also call it as respiratory asthma. Now, before I get back to cough, I have one basic physiology questions to all of you. I think we have already learned that whatever air that stays in the conducting airway does not participate in gas exchange. So what do we call it as? See, this air is of no use, means it is not participating in gas exchange. Whatever oxygen is there, which is stuck in the conducting airway, it's not going to get absorbed. We are not going to gift any carbon dioxide to this air. So what do we call it as? We call it as anatomical dead space. So that is another important physiology point that I want you to remember. Air that stays in conducting airway during respiration will be called as anatomical dead space. They often ask you what is the normal value of this anatomical dead space. Means whatever air is there in this space is not going to participate in gas exchange, which is approximately 150 ml. True teller, absolutely right. We call it as anatomical dead space. Okay, now I think we touched upon some basic physiology points. Let us get back to our discussion of cough. What is cough? Cough is a primitive reflex which acts as a defense mechanism against invading foreign pathogens or dust particles, or in simple words, foreign materials, when your ciliary belt alone is not sufficient. Now let us look at what Harrison says about the cough. This is what Harrison says about cough. Cough performs an essential protective function for human airway. And he says, without an effective cough reflex, we are at risk of retained airway secretions. Whatever secretions we produce, we will not be able to throw that out. We sometimes need cough to bring that out. And thus aspirated material may predispose to infection, collapse of the lung. Atelectasis is a word used for collapse of the lungs, and compromise of our respiratory system. So cough is an important reflex. First point. So now, having that very clear, cough is a reflex. Obviously, whenever we talk about reflex, we have to talk about reflex arc, because every time we have a reflex, it includes a sensory stimulus. I gave you an example. I touched a hot pot. Heat, temperature is a sensory, it's a sensation, right? It's a sensory stimulus. So through sensory neuron, it will go to my spinal cord, and then I have to, the withdrawal of the limb is a motor response. It's a movement, right, done by contraction of muscles. So I gave a sensory input. The result I got was a motor response. So every reflex will have a sensory input, a motor response, and something which couples the sensory and motor response. In case of all your physical reflexes, including the knee jerk, ankle jerk, all the deep tendon reflexes, superficial reflexes you do, they are all called as spinal arcs or spinal reflex arc. Just to give you an imaging example, whenever we have a reflex arc, we stimulate a sensory receptors, like the hot touch, the example I gave you. The sensation reaches the spinal cord. There it hands over the impulse to one more neuron called as interneuron, and then interneuron hands over the information to a motor neuron. The motor neuron, which originates in the spinal cord and goes to the muscle, we call it as lower motor neuron. So this lower motor neuron sends the signal for the muscles to contract, and that is how I end up withdrawing the hand. Now cough also being a reflex, we have to know what is the sensory or apparent pathway, what is the motor or efferent pathway, which receptors needs to be stimulated to activate these afferent neurons, and where the coupling of sensory and motor receptors happens, right? So that's what we will address in how cough is produced. Now to produce cough, we can have like see for example, if you throw chili powder at somebody, they start coughing, right? All of us have experienced, sometimes our mother is cooking some spicy food in the kitchen, we start coughing. Why? Because we are inhaling substances which are chemical in nature, which can trigger. So we can trigger cough by chemicals as well as mechanical. Like suddenly while drinking water, some amount of water goes into my airway, I start coughing, right? So obviously water is an inert substance, it doesn't act as a chemical, but still it can. So when we stretch the airway, we stimulate mechanoreceptors, or when we give chemicals to the airway, we stimulate chemoreceptors. So chemoreceptors are primarily of two types. The first one is called as TRPV1 and TRPV4. Now what does that stand for? It stands for transmembrane receptor potential vanilloid 1 or 4 receptors. The second receptor is called as P2X3. Now you may be thinking why sir is talking about receptors and all, but once you go to pharmacology and study about cough suppressants, which is an important topic for you, you will understand the importance of knowing these two receptors. So you have chemoreceptors which are triggered by TRPV1, like the receptors are TRPV1 or 4 and P2X3. Now these are the receptors which get stimulated by the chemical. Particularly, I want you to remember that this TRPV1 can be stimulated by what we call as capsaicin. Capsaicin. Okay, have you heard about this word capsaicin anywhere? Capsaicin. Have you heard about it anywhere? Capsaicin is the principal irritant compound present in your chili powder. So when somebody is cooking and it's spicy and the chili is dispersed in the atmosphere and we start coughing, it is because of this capsaicin. Capsaicin stimulates TRPV1 or TRPV4 receptors. And in fact, when we develop drugs for cough suppression, to test their efficacy in animal model, this is what we do. We expose them to capsaicin, and then we'll see whether the drug is able to prevent cough in them upon exposure to capsaicin or not, if it is a cough suppressant drug. Okay. Then mechanical, when we stretch the receptors, we can trigger the cough. Okay. Now let us look at what Harrison says about it. So he also says that cough can be activated by cationic channels called as transient receptor potential channels, TRPV1 and 2 I told about, and then adenosine triphosphate activated channels called as P2X3, right? So these are the important receptors repeatedly asked MCQs with respect to pharmacotherapy, because we have started developing drugs which block these receptors. So there can be two receptors, chemoreceptors or mechanoreceptors. So when we irritate the receptors, we trigger the cough. But once the receptors in the airway epithelium are irritated, how the neurological system gets to know that, okay, I need to cough now? We have to have apparent neurons. Now what are the apparent neurons here? We have A delta and C fibers. These are types of neurons which you might have studied in your physiology. There are two types of neurons, A delta and C fibers. A delta and C fibers of two nerves. Vagus is the most important nerve which acts as an afferent. So our upper airway, lower airway, till our terminal bronchiole. I told you about it already, right? Terminal bronchiole, which is part of our conducting airway. So from nose till terminal bronchiole, we have these cough receptors, and it is well innervated structure. And this is the vagus nerve which carries the sensation of irritation to the cough center. So vagus nerve acts as the most important apparent pathway. Okay. Now this vagus nerve takes the sensory stimulus to a cough center which is present in the medulla. Medulla is part of your brainstem, and we call that center as nucleus tractus solitarius. Again, this is an important MCQ from physiology. Where is the cough center present? Cough center is present in the medulla, and we call it as nucleus tractus solitarius. Okay, so when you see this image, you will probably understand. We have receptors for cough present in your airway. These receptors will get stimulated on exposure to chemicals or mechanical stretch. Once they are stimulated, our vagus nerve gets the information, the sensory input, and takes that sensory input to the medulla, where we have the cough center. It is called as nucleus tractus solitarius. Okay. Once the nucleus tractus solitarius receives the information, it has to send an efferent response for us to cough, right? So through which receptors or through which nerve we send the efferent response? The efferent response is sent through three nerves. The first nerve is our glossopharyngeal nerve. The second nerve is vagus again. Vagus is afferent as well as efferent. And third and most importantly, the phrenic nerve. So now let me summarize what happens when we cough. Suppose I inhale this chili flakes. Now my TRPV1 receptors are activated. Through the vagus nerve, this information will reach the nucleus tractus solitarius in my medulla. Now that will send the motor signals through vagus nerve, glossopharyngeal nerve and phrenic nerve for me to contract my diaphragm, intercostal muscles. The only difference is, see, when I am taking an inspiration, I am contracting my diaphragm, intercostal muscles, right? The main difference here is the cough is an exhalation process, but normally when I am exhaling, I am not creating any obstruction to its exhalation. But when we cough, what we do is, we contract our diaphragm, we contract intercostal muscles so aggressively, but we also contract the glottis. We close the glottis, and because we have closed the glottis, inside our thorax or airway, we generate sufficient strong pressure, and then all of a sudden the glottis is opened. So now explosively all the air comes out. So while it is coming out, it will take out all the foreign material, secretions and pathogens out. That is how we cough. So how do we cough? We contract all the muscles keeping the glottis closed so that we generate strong pressure inside the airway. And then suddenly we open the glottis and thus we exhale explosively. So can I say cough as an explosive exhalation or explosive expiration? That is what it is, an explosive expiration, right? So this is what we call as the cough mechanism. All the points we studied today are important MCQ points. What are the cough receptors? We have TRPV1, 4 and P2X3, important cough receptors. Which nerve is the operant for the cough reflex? It is the vagus nerve. What is the cough center? It is the nucleus tractus solitarius. And where is the efferent pathway? Efferent pathway includes glossopharyngeal, vagal and phrenic nerve. All the muscles involved in respiration should be contracted. Now let us look at what Harrison says about it. So he says same thing about cough mechanism. He says that the cationic transient receptor potential channels TRPV1, TRPV4 and P2X3 act as receptors, and the signals are transmitted centrally via A delta and C fibers. Afferent nerve endings richly innervate pharynx, larynx and airways to the level of terminal bronchioles. And there are also one important point which I missed and I want you to primarily focus on. Sometimes when you are putting the earbuds, people tend to cough. Sometimes while swallowing, if food gets stuck, we tend to cough. Food gets stuck in the esophagus, but we tend to cough. Sometimes while doing endoscopy, we are pushing the endoscope into the esophagus, patients tend to cough, right? What could be the reason? Because the cough receptors are also present in the esophagus and they are also present in the external auditory canal. Now my question is, tell me from your anatomy knowledge as well as physiology knowledge, what is the nerve supply here? What nerve I am stimulating when I put the earbuds for me to start coughing? Basic anatomy question it is. So we call that nerve as Arnold's nerve. It's called as Arnold's nerve. It's the auricular branch of the vagus nerve which can get stimulated and we can cough. So cough need not always be originating from the respiratory epithelium. Madhumita, absolutely right. Arnold's nerve or a branch of vagus nerve. Good. So this is how when we study medicine, we will be able to relate to physiology and anatomy. So we will kind of revise, learn more physiology, apply it to medicine, same time touch the principles of pharmacology, pathology and move forward. Okay, so now I think we have a fair idea about what is cough. It's a reflex, it's a protective reflex. How it is produced, the whole mechanism, what is the receptor, afferent, efferent pathway and where is the cough center present. Now let us get to the medicine part of it. How to approach a patient presenting with cough. So there are two things we need to concentrate on when a patient presents with cough. The first one is the duration of cough. Objectively, you should know when to call it as acute cough, when to call it as subacute cough, and when to call it as chronic cough. These are the three terminologies which you may be already exposed because of your bedside postings. You know there is something called as acute, subacute and chronic. And right now only let me tell you that these terms acute, subacute and chronic, they are not standard with respect to numbers. A chronic diarrhea is which is present for more than 4 weeks. But chronic cough more than 4 weeks is not chronic cough. So for every symptom we should know when it is counted as acute, subacute and chronic. That is first thing. We should know the duration of cough, and the second thing we should know is whether the cough is productive or non-productive. Means when I say productive, it means whether it is associated with sputum or whether it is associated without sputum. Productive cough stands for cough with sputum. It is producing sputum. These two things will help us to narrow down our differential diagnosis whenever a patient presents with cough. So we will do that. First we will look at the duration, which I think med student has already mentioned it. Less than 3 is acute, 3 to 8 weeks is subacute and more than 8 weeks as chronic. Absolutely right. So we will call it as acute cough when the duration of cough is less than 3 weeks. Then we will call it as acute cough. So can anybody tell me when do we call it as, like, what are the common causes for acute cough? 3 to 8 weeks, as he has mentioned, we call it as subacute, and when it is more than 8 weeks we call it as chronic cough. So can anybody tell me what are the common causes for acute cough? All of you have experienced one episode of cough in last 12 months, right? Most of us have gone through some episode of cough in last 12 months. So what was the common cause there? Did we have tuberculosis? Did we have cancers? No, right? So then what was the cause? So acute cough can be infectious because of infections, or it can be non-infectious. And overall it is the infections which are the most common cause. So when I say MCC, it stands for most common cause, infections of the respiratory system. And within that, as we know, upper respiratory system infections are much more common than the lower respiratory infections. So upper respiratory tract infections are more common, like as Debu mentioned, as others mentioned, the sore throat and all. Yes, they are the most common cause for cough. Upper respiratory tract infections are more common than the lower respiratory tract infections. Now one more question that we should address, because whenever someone presents with cough, if it is acute, we know it is mostly infectious. The question is, should we give antibiotics? And we have to remember that when we talk about infections, most common infection is not bacterial, it is the viral, and that is why we should not unnecessarily prescribe antibiotics to simple upper respiratory infections. Sore throat, we end up taking azithromycin, ciprofloxacin, but most of the times they are not useful. They contribute to emergence of resistance, because 85% of patients with sore throat, they have sore throat because of viral infections. Okay, so viral is more common than bacterial. Okay, now when we get a patient presenting with acute cough and there is no infection, what could be the cause? Most of the non-infectious acute coughs are basically because of acute exacerbation of chronic cough. Means patient has a chronic disorder which is known to cause chronic cough, but then he was probably well controlled. Out of the blue, the cough gets exacerbated. Just to give you an example, like asthmatic, last 1 week, like last 1 month, 2 months, he did not have an asthma attack. Now he has an asthma attack, he starts getting cough. So when he comes to us, the duration of cough is only 2 days, 3 days, so we will count it as acute. But his disorder is chronic. Asthma is there from several years in him. So it is just the exacerbation. Infections are the leading cause for acute cough. If it is non-infectious, it is mostly because of acute exacerbation of a chronic disorder. Okay. Now when it comes to subacute cough, can anybody tell me what could be the most common cause? Today, if you get a patient who is coughing for more than 3 weeks, What could be the most common cause? Right now I can say that most of you might have a batchmate in your class who is coughing in the background when class is going on. Someone is coughing in the background and he may be coughing for last 3 weeks, 4 weeks. Does that mean that he has some major infection? Does that mean that he has major infection? Madhumita, pneumoconiosis or the pneumonia is generally present as acute cough. See, if it is a viral or a bacterial pneumonia, for example COVID, at the end of 3 weeks most of the patients would have recovered, or they would have been extinguished by the infection, like they would have died with the infection, right? Unlikely that the pneumonia would persist beyond 3 weeks time. By that time patient would have gone into what you study in pathology as gray hepatization or a recovery stage. Okay, so what is the most common cause? So the most common cause for subacute cough is what you call as post-infectious tussive syndrome. Tussive syndrome. An important terminology I am introducing, and this is an important concept that all of us should know, because you will have many friends, family members and relatives who have been coughing for quite some time now, and most of them don't have infection, and they would be going to different doctors repeatedly. Every doctor will be giving a new antibiotic to them, which is money down the drain and unnecessary risk of getting a resistant infection. What is this post-infectious tussive syndrome, which can also be called as post-viral tussive syndrome? Remember guys, tussive stands for cough, right? Antitussives, that is the title in your pharmacology textbooks for cough suppressants. So tussive stands for cough. So after infection, many patients continue to cough for a long period of time. What could be the reason? Because whenever we get infected, these cough receptors we studied, right? Chemoreceptors, mechanoreceptors, they get upregulated. Now what do I mean by upregulated? Their numbers increase. Like TRPV1, 4, P2X3 and other mechanoreceptors, their numbers increase. And if their numbers increase, whenever we get exposed to even minimal mechanical change or small dust exposure, it will irritate and trigger the cough. Because there are too many receptors, it is easy to stimulate for even small amount of dust which a normal person may not be stimulated. Sometimes these patients, while talking also, just that movement of air column triggers the cough. You might have seen many of your classmates or you, when you go through some sore throat, after that you make a recovery, but then you continue to cough for 2 to 3 weeks. And during that time, when you have hesitation to sit with your friends, you have hesitation to talk to your teachers or friends, because while talking only suddenly a bout of cough comes. Why that happens? Because there is increase in the cough receptors. So it is very easy to stimulate them and you end up triggering the cough. So the mechanism here when we have this post-tussive syndrome is there is increased number of cough receptors. I am putting it in simple words. When you write it down in your final prof exam, you can say there is upregulation of cough receptors. So it is much more easy for us to stimulate these receptors. But in India, there is one more cause which is a concern, right? That is tuberculosis. As we know, any patient who presents with cough of more than 2 weeks duration, in India, we always consider tuberculosis as a differential diagnosis. So when I was doing MBBS, we used to say, start investigating for tuberculosis if the cough duration is more than 3 weeks, because most of them present as subacute or chronic coughs. Now the government guidelines clearly tell us that 2 weeks or more than that, we have to investigate for tuberculosis. So tuberculosis is a second important concern when it comes to subacute cough. So first and the most common one is what we call as post-infectious tussive syndrome, which is due to upregulation of receptors. Second one is tuberculosis. Every other condition that generally produces subacute will end up becoming chronic. So we will discuss them under chronic cough conditions. Now when it comes to chronic cough, means cough present for more than 8 weeks. We will divide those cough patients or chronic cough patients into 2 broad groups, because as you look into Harrison, he mentions a very important statement. This is a very, very important statement, right? Look at the statement. It says, in virtually all instances, evaluation of chronic cough merits a chest X-ray. Merits a chest X-ray. Means what? When you have a patient presenting with cough of more than 8 weeks duration, chest X-ray is a minimum starting point. You can't just prescribe some medications and send them. Minimum thing you need to do is do a chest X-ray. And when I do a chest X-ray, two things are possible. Either I encounter an abnormal chest X-ray or I encounter a normal chest X-ray, right? So we will divide these patients of chronic cough with those with the abnormal chest X-ray and those with the normal chest X-ray. Chronic cough, cough more than 8 weeks with abnormal chest X-ray and cough more than 8 weeks with normal chest X-ray. Now as you progress, you will definitely learn more about the conditions where you can have abnormal chest X-ray, because all of those disorders like tuberculosis, lung cancer, COPD, chronic infectious diseases, interstitial lung disease, pneumoconiosis, all of them we will be dealing individually one by one. But for now we will just make a list of it. So you can have abnormal chest X-ray when you have chronic pneumonitis, which includes infectious as well as non-infectious. Then it can be because of the lung cancers. It can also be because of non-cancerous lung tumors. I think recent times everyone is familiar with Yuvraj Singh's story, right? So he also had cough, chronic cough, but imaging found out that he had an abnormality. So non-cancerous lung tumors. Then tuberculosis can also present as chronic. There are certain infections which can present as chronic, which you can count under the chronic pneumonitis, like for example HIV individual, they may present with pneumocystis jirovecii infection, which can be chronic. Similarly, they can also develop cryptococcal pneumonia, which can be chronic. So chronic pneumonias are known to occur in especially immunocompromised individuals, lung cancers, non-cancerous lung tumors, tuberculosis, right? So in all these conditions, you can have pleural diseases like mesothelioma, and then last but not the least, what you call as pneumoconiosis, right? What pneumoconiosis stands for? Pneumoconiosis stands for occupationally acquired interstitial lung diseases, means those respiratory disorders which affect the lung parenchyma and you acquire them because you got exposed to some noxious, dangerous substance at your workplace, like for example exposure to asbestos or coal dust in your, like if you're working in KGF, that dust particle exposure. So those we call them as pneumoconiosis, which you will study more in more detail in preventive and social medicine. And last but not the least, interstitial lung diseases. There are some set of disorders which affect the lung parenchyma, means connective tissue and alveoli. They don't affect the airway. So all of these, you will have an abnormal chest X-ray, or if you have done other imaging, they will be abnormal. Now today's focus will be more on those conditions where you have chronic cough but yet you have normal chest X-ray. You have chronic cough but we have normal chest X-ray. In Harrison, he has created a separate section of it where he describes it, chronic cough with a normal chest radiograph. This becomes an important 5 marks question for your final prof, and this is also an important topic for discussion during your viva OSCE or during your bedside discussions where where the examiner holds a normal chest X-ray. With him, he has a patient who has cough present for several weeks, and then he will ask you in what conditions you can have chronic cough but chest X-ray turns out to be normal. Okay, so let us look at what all Harrison mentions. And let me tell you first, the most common cause for a chronic cough with abnormal chest X-ray is normal chest X-ray is nothing but asthma. Many asthma patients do have cough. And now that we are talking about asthma, let me tell you one sub-variant of asthma which is called as, see, any patient of asthma can cough. But what is the main complaint that they come to hospital? They come to hospital because of shortness of breath and because of wheezing. Cough is less likely to bring them to the hospital. But there is a variant of asthma called as cough variant asthma. Cough variant asthma. Regarding this, in the recently concluded, means the last INI, there was a question. In which age group this cough variant asthma is common? So in some set of individuals, instead of developing wheeze, they cough more. and it is a cough that brings them to the hospital. We call it as cough variant asthma. This is typically more common in children. It is quite rare in adults. Adults always wheeze and they come to hospital because of the wheeze. And Harrison also emphasizes this point, the cough variant asthma. Let me trace it if he has mentioned it somewhere. Cough as a manifestation of asthma is common among children but not among adults, and we call this as, it is referred to as cough variant asthma. So this gives you an important MCQ point. Which age group is most likely affected by this variant of asthma called as cough variant? So asthma overall is the most common cause for chronic cough with normal chest X-ray. This accounts for around 35% of patients. So you can say that more than one third of patients who present with chronic cough and their chest X-ray turns out to be normal is going to have asthma. Okay. Now I forgot to mention one important condition for chronic cough, which is the COPD. COPD, we generally end up getting some abnormal chest X-ray. Means in COPD you have two components, as you know. One is called as chronic bronchitis. The second one is called as emphysema. Emphysema is where there is irreversible dilatation of the alveoli. Because of that, lung size increases. The increased lung size is very easy to recognize on the chest X-ray with the flattening of diaphragm and increased intercostal spaces and a tubular heart. Okay. Anyway, you don't need to really bother right now about all these conditions because individually they are all important topics and we are definitely going to deal with them. Now switching our attention back to what we were discussing. Normal chest X-ray but chronic cough. Asthma is the most common cause and the second most common cause, almost accounting for 1/3 or 33% of cases, is now what we call as upper airway cough syndrome. Most of you are familiar with this disorder but with a different name. We call it as upper airway cough syndrome or UACS. Okay, can anybody tell me what is it also alternatively known as? Okay, see, if someone presents with chronic cough and chest X-ray appears to be normal, asthma is one condition. Second, most of the students generally answer saying that post-nasal drip. So when you have chronic sinusitis, chronic rhinitis, you have a post-nasal drip. The secretions go to your throat. From there, they cause irritation of the throat as well as the upper airway. Sometimes secretions can trigger into the trachea and trigger inflammation there and can cause cough. Cough because of post-nasal drip. So that is what we now collectively call it as upper airway cough syndrome, which is mostly due to post-nasal drip. Where we get post-nasal drip? When we have chronic sinusitis, chronic rhinitis or chronic rhinosinusitis. From there, pus and secretions trickle into your throat, especially when you sleep in the night. Irritates and inflames your upper airway as well as may trickle into the trachea, irritate and cause inflammation and can become a reason for cough. That is the second most common cause. Okay. Now there is a third condition which has received a lot of attention in the recent times. But before I go there, let me take you through what Harrison talks about this upper airway cough syndrome. So Harrison mentions that upper airway cough syndrome has been coined to encompass the concept that chronic inflammation in the nose and sinuses can cause cough, and sometimes even in the absence of physical drainage into pharynx. We have moved away from using the post-nasal drip induced cough as a terminology and instead we have started calling it as upper airway cough syndrome for one important reason, because 2/3 of these patients have clear evidence of post-nasal drip, but 1/3 have chronic rhinosinusitis. We can't see the post-nasal drip, but they still have cough. So all combined, we have called it as upper airway cough syndrome. But 2/3 cases are because of post-nasal drip. Okay. Now the third condition which can cause this chronic cough with normal chest X-ray is when you have what we call as another closely related condition, very similar to asthma. You should tell me what is the difference between asthma and this. It's called as non-asthmatic eosinophilic bronchitis. We often call it as non-asthmatic eosinophilic bronchitis, NAEB. Can anybody tell me what is the difference between this and asthma? If you're in second year and you have already studied respiratory pathology, you might know that in asthma, eosinophils play a very important role in causing the airway inflammation. And we know that asthma is a disorder which affects the bronchi, where there is bronchoconstriction. And inflammation here is triggered by eosinophils. But in asthma, there is not only airway inflammation but bronchoconstriction. There is narrowing of the bronchial tree. Because of that, patients experience wheeze as well as cough because of the inflammation. Non-asthmatic eosinophilic bronchitis is a condition where patients have eosinophilic inflammation of the airway, but there is no bronchoconstriction. So these patients won't have wheeze, right? So the difference between this and asthma is between asthma and non-asthmatic eosinophilic bronchitis. So let me put a small table talking about this, because this is an important point I want you to know now itself. So asthma, you have eosinophilic inflammation of the airway, inflammation plus bronchoconstriction. So that will lead to both wheeze as well as, so this will lead to wheeze and cough, wheeze plus cough. In these non-asthmatic eosinophilic bronchitis, there is only eosinophilic inflammation, eosinophilic inflammation, but there is no bronchoconstriction. And because there is no bronchoconstriction, these patients generally don't get wheeze. So there will be only cough, no wheeze. So if I have to treat a patient with asthma, right? Remember, if I have to treat a patient with asthma, I need to give an inhaler which contains a bronchodilator as well as an inhaled steroid to reduce the eosinophilic inflammation. If I have to treat a patient with non-asthmatic eosinophilic bronchitis, I have to give only steroid inhaler. There is no need for the bronchodilator. That is the main difference here. Okay. Now we have only one last cause for chronic cough with normal chest X-ray left, and that is your GERD, gastroesophageal reflex disease. So how many causes we studied for chronic cough with normal chest X-ray? First one was asthma. The second one was upper airway cough syndrome, which is nothing but your postnasal drip. Third was similar to asthma but no bronchoconstriction. We call it as non-asthmatic eosinophilic bronchitis. And the fourth one is GERD. Now what happens in GERD? Because of the incompetence of the lower esophageal sphincter, acid refluxes into esophagus. Sometimes from the esophagus it can pass through the larynx. From the esophagus it can get into the oropharynx, get into the larynx, go to the trachea and bronchi, and there it can trigger the bronchitis. And when we have bronchitis, obviously we are irritating those mechanoreceptors and the chemoreceptors, and we can end up getting cough, right? So if I have to treat these patients, instead of giving them cough suppressants, I should give them proton pump inhibitors and prokinetic agents. I have to treat their GERD, then their cough will come down. If I just go on giving the cough suppressant, it doesn't help the patient. So now let us see what Harrison talks about this reflux. He says reflux to the level of pharynx. If the reflux come to the level of pharynx, right, then we will call it as laryngopharyngeal reflux, and as a consequence of gastric aspiration of gastric content, it causes chemical bronchitis and possibly pneumonitis that can elicit cough for days afterward. But it is a rare finding among persons with chronic cough. That is why, see, this is not a much common entity, and that's why I have listed it as a fourth cause. So in terms of priority, first and the most common cause is asthma, followed by upper airway cough syndrome, followed by non-asthmatic eosinophilic bronchitis and GERD. So now, so far what we know in terms of cough duration, we can call them as acute when it is present for less than 3 weeks. Most of the acute coughs are because of the infections or because of exacerbation of a chronic disorder. When it comes to infections, it could be viral or bacterial. Viral is more common than bacterial. Subacute means it lasts for 3 to 8 weeks. Most common cause is post-infectious tussive syndrome, where you have a upper respiratory or lower respiratory infection, mostly maybe viral. So during that infection you would be coughing, but after that, because the receptors are upregulated, you will continue to cough for several weeks. Okay. In India, we have an additional concern, which is tuberculosis, which can present as subacute or chronic cough. Now, chronic cough is when it is present for more than 8 weeks. Our approach to any patient with chronic cough is whether the chest X-ray is normal or whether it is abnormal. If the chest X-ray is abnormal, mostly it is self-explanatory. It will lead to diagnosis based on the chest X-ray findings. But if chest X-ray is normal, it can be because of asthma, which is the most common cause here. It can also be because of the post-nasal drip, what we called as UACS, or it can be because of non-asthmatic eosinophilic bronchitis, or it can be rarely because of GERD. Okay. So when we studied about approach, first thing I told you, we will concentrate on duration. So now duration itself help us to differentiate or rule out some condition and rule in some conditions. Now let us look at how knowing whether there is sputum production or not helps us to differentiate different types of cough. So we will call it as productive when there is cough with sputum production. We will call it as productive when there is cough with sputum production. If there is cough without sputum production, then we will call it as non-productive cough. Cough without sputum production is called as non-productive cough. Okay, so now tell me in what all conditions you can get a productive cough. What all conditions you can get the productive cough. So causes for productive cough include, number one, infections, right? Infections are overall most common cause for acute cough. Infections do contribute to subacute and chronic cough, and most of the infectious coughs are productive. Especially if it is like viral can be productive, bacterial can be productive, especially bacterial. You know that there is something called as typical and atypical organisms. Typical organisms generally produce productive cough. In second year or third year, right now don't bother about typical atypical organisms. As you complete your microbiology, you will understand more about it, and I will discuss more about typical and atypical pneumonias later when we take up pneumonia as a topic. Okay. Second, cough with sputum production. Where else we can get? Yes, in COPD. In COPD, there is a subcomponent called as chronic bronchitis. Can anybody tell me how do we define chronic bronchitis? What is the definition of chronic bronchitis? When you have productive cough for 2 consecutive years, more than 2 months per year for 2 consecutive years, we call it as chronic bronchitis. So in the definition only, we mentioned it very clearly that when you say chronic bronchitis in a COPD patient, you are addressing presence of sputum production. In fact, good amount of sputum production. Okay. Then the third condition where you can have cough with sputum production apart from pneumonias and chronic bronchitis is when you have lung abscess. So infections here primarily I refer to pneumonias and upper respiratory tract infection. Most of us when we have sore throat, we have sputum production, right? So upper respiratory tract infections as well as pneumonias. If I have a lung abscess also, I can have the sputum production. Then fourth, another condition where I can have sputum production is if I have a condition called as bronchiectasis. Now what bronchiectasis refers to? Emphysema, I think you're familiar with this term, refers to irreversible dilatation of alveoli. Bronchiectasis refers to irreversible dilatation and destruction of the bronchi. So if bronchi become irreversibly dilated, we will call it as bronchiectasis. We already know that bronchial wall has smooth muscle layer, so it can constrict or relax, and that is why when there is constriction we get asthma. We give relaxants, bronchodilators to dilate it, but if it is irreversibly dilated, then we will call it as bronchiectasis. In all these conditions we can have cough with sputum production. Now there is one last point to learn here. Now often examiners during your bedside discussion ask you, when do you say patient has got copious sputum production and when do you say he has got mild or scanty sputum production? Because when they are producing sputum, right, sputum can be scanty or copious. Sputum can be scanty, or it can be copious. To call it as copious sputum production, it should be more than 60 ml per day. Some examiners say more than 1 cup if the patient, because patient may not be able to tell you the quantity of sputum he is producing, so he may express in terms of cups. So regular, your teacups, right? I'm not talking about the regular size teacups, those you get in your college canteens and all those small cups or small glasses, they are roughly 60-70 ml. So if patient says that he is producing more than that amount of sputum, then it is copious sputum production. If it is less than that, you can say mild or scanty sputum production. Now in what condition I can get copious sputum production? As of now, I want you to think of mainly 3 conditions where you can have copious sputum production, and those are your chronic bronchitis, lung abscess and bronchiectasis. You can have copious sputum production. Okay, in fact, in the definition of chronic bronchitis, we mentioned that copious productive cough. Now, in what all conditions I can have non-productive cough? We can have non-productive cough in conditions like interstitial lung diseases. Remember, there is one statement in Harrison which says if you have a patient with interstitial lung disease and they present with productive cough, we should think of secondary infections, because ILD per se is not supposed to cause the sputum production, right? Similarly, reactive airway disease, reactive airway disease. This is also something which is not supposed to lead to good amount of sputum production. Patients will present with scanty or no sputum production when we have reactive airway disease and interstitial lung disease. For now, we can go on and on listing many of these conditions, but our focus is to concentrate on what are important, because in the exam, examiner will also not have sufficient time to go on listing your causes. The moment you tell them first 2 or 3 important causes, they're done with it. Generally, they move to the next question. And even if you can't go further, you will not be failed. As an experienced examiner, I can assure you that if you are able to answer first 2 or 3 important conditions for any question asked by the examiner, you are already passed. Even if I am asking next, can you tell me the next cause, it's only because I want to give you extra brownies points. If you answer more, I will give you more extra points. But by the time you have answered 2 or 3 conditions, you are already, your boat is sailing towards passing. Okay, so this is about the productive nature of the sputum. Now, can the sputum color influence my diagnosis, or can I clinically predict whether this is caused by this particular organism or that particular organism by looking at the sputum color? This is another information I want whenever I am dealing with cough. I know all this is not there in the Harrison, but during your bedside discussion, these points come up. So, sputum color may give you some clues towards the diagnosis. So, the first one is when you have a rusty colored sputum. Rusty colored sputum means, you know, that iron, when it gets rusted, slightly brownish. So, if you have such sputum, it generally indicates that you have got a Streptococcus pneumoniae infection. Streptococcus pneumoniae infection. You will definitely find images of rusty colored sputum in your microbiology textbooks. You can paste those images in our notes. Second, you can get bluish green sputum. Which organism can produce bluish green sputum? Blue, right? Whenever we hear blue, which bacteria comes to your mind? Anybody commenting on it? Yes, that is the Pseudomonas. So, Pseudomonas infection, if you have Pseudomonas pneumonia, you can produce bluish greens colored sputum. The next one, I think this is examiner's favorite, and I am very sure all the second year, third year students know about it, which is red currant jelly sputum. Red currant jelly sputum. So, first of all, what is this red currant? We know black currant, right? The fruits. Similarly, there are fruits called as red currants. So, when a jelly or a marmalade is prepared from it, it looks kind of like jam, and such, if the sputum also resembles that, we will call it as red currant jelly sputum. In fact, in our medical college, when we were doing the exam, I wanted the students to spot different types of sputum, and when I couldn't get the specimen for the red currant jelly sputum, we didn't have any patient with severe pneumonia caused by this particular organism. All I did was I slightly diluted the jam and put it on a petri dish, and we had kept it. And obviously students know it, so they answered it. Almost resembling like diluted jam or marmalade, which is seen in infections caused by Klebsiella. So Klebsiella pneumonia can cause red currant jelly sputum. So with respect to cough, when we get the cough history, first thing we have to understand is the duration of cough, whether we are dealing with acute cough, subacute cough or chronic cough, and then we have to understand whether patient is having cough which is dry or which is associated with sputum production. And if it is associated with sputum production, I would be interested in knowing the quantity. Whenever patient says that he is producing massive amount of sputum, I would think of conditions like lung abscess, chronic bronchitis, as well as the third entity that we listed here, which is bronchiectasis. Then second thing, I might be interested in knowing the color of the sputum, whether it is white or yellowish. As you know, yellowish indicates that it is infected sputum, points towards infection, but certain specific colors may help us to suspect specific organisms. So if there is rusty colored sputum, it indicates Streptococcus pneumoniae. Bluish or green sputum indicates Pseudomonas, and if it is red currant jelly or red jelly like sputum, it indicates Klebsiella infection. Okay. Now having done with that, I will take you to the last bit of our understanding of cough, which is very important in the recent context, which is called as impaired cough. We began our discussion by understanding that cough is an essential reflex which nature has bestowed us to protect our airway. In our definition only, we mentioned that it is a reflex which kind of functions like an immune system which protects our airway and lungs. But many conditions we may not be able to cough, and if you are not able to cough, that can lead to the complications, right? So let us look at what Harrison says about this impaired cough. Impaired cough. Impaired cough he defines as weak or ineffective cough. Weak or ineffective cough that compromises the ability to clear the lower respiratory tract secretions, predisposes to more serious infections and their sequelae, right? So let us write it down. What is impaired cough? It means weak or ineffective cough. Ineffective cough. Very often in your wards, you might see patients who will be just coughing like that. They have some major lung infection. When their chest x-ray, you see infection everywhere, right lobe, right lung, left lung, extensive infection, but they will be coughing like that. It's a weak or ineffective cough. Instead of proper chesty cough to bring out all the sputum, they will have weak or ineffective cough. And that increases the risk of major serious infections because they are not able to clear their airway, right? Now, in what all conditions we can have such weak or ineffective cough? That's an MCQ. That's the question that examiners will ask you standing next to the patient. So I want you to remember this table from Harrison. As long as you remember 3 or 4 causes, your boat will sail. The first one is weakness of respiratory muscles. In what conditions we can have weakness of respiratory muscles? One example I can quote is GB syndrome, where ascending paralysis has reached the respiratory muscles. That's an example. Severe hypokalemia, when potassium is very low, muscles will not be able to contract well. Okay. Then when we have severe lactic acidosis or any cause for metabolic acidosis, muscle metabolism will be impaired. So there are long list of disorders which can cause impaired functioning of the respiratory muscles. If respiratory muscles cannot contract well, obviously we can't cough well. Okay. Now if we have chest pain mainly originating from the chest wall, like you have some trauma, there are fractured rib. Because if I try to cough, it hurts. So subconsciously I will try to suppress the cough. I think in the beginning only we have learned that cough is a reflex, but we can have a voluntary control. Like if the social situation does not permit me to cough, I can try to avoid it as much as possible. So many of these patients, when they have chest pain because of some damage to the chest wall, they will try to suppress the cough. So then obviously they will not be able to cough openly, cough well. Same applies to abdominal pain. So if I have abdominal pain, I cough, my abdomen hurts, so I will avoid. Patients with chest wall deformity will have difficulty to cough. right? And then those who have difficulty in the closure of the glottis. See, how do we cough? We contract our respiratory muscles and diaphragm, keeping the glottis closed, and then we open the glottis suddenly, and that is how we will be able to expel all the secretions out. But if I am not able to close the glottis, then I will not be able to generate such pressures inside the airway. Then if you have central respiratory depression, which is very common in medical practice, it is generally because of sedation or use of opioid analgesics. In OT, it can be because of anesthesia, right? If I have abnormal airway secretions, ciliary dysfunction, tracheobronchomalacia, which is nowadays common because of long-standing endotracheal intubation, bronchiectasis and tracheal or bronchial stenosis. From this table, please remember at least 3 or 4. May not be important for MCQs, but during bedside discussion, it is important. And what is the consequence? If there is impaired cough, there will be increased risk of severe infections because we can't clear the secretions from the airway. So there are definitely sequelae if patient has got impaired cough, right? So that's all Harrison addresses, but he opens up one important channel of discussion. Once we are done with all of that, we have a fair idea what are the common causes for cough, how patients present, from the examination findings and clues, how we can zero down on some possibility. But he also opens up an avenue for us to learn more. Symptom-based treatment of cough. This is where the pharmacology begins. I will only give you a brief overview. You can definitely go back to your pharmacology books and study more. Now, whenever I have a patient who is coughing, what all I need to do? If there is a patient who is coughing, first thing I have to decide whether I need to suppress the cough or not. Many times patient is bringing out the inspissated secretions or the sputum, which like the infected pus, that needs to be brought out. In such cases, we should not suppress the cough, as we have already known that if there is an impaired cough, in fact that will be more harmful to the patient. So we should let the patient cough. Only to make it bit more easier for the patients, we can give drugs called as mucolytics, which will break down the thick sputum into easily expectorable or easily coughable out sputum. So whenever we have, for example, we have infectious cough, we shouldn't be giving them cough suppressants. Instead, give them the mucolytics. They will break down the sputum and bring it out easily. They should bring it out. Cough is a defense mechanism. But in conditions like where I have GERD or where I have the asthma, where this is not a defense mechanism, this is definitely becoming a nuisance to the patient. It is impairing their quality of life. In such circumstances, what should I do? We have to think of cough suppressants. So if I have to suppress the cough, what all I can do? One and most commonly used mechanism is suppress the activity of nucleus tractus solitarius. Means your vagus nerve will be sending the input to it, information to it, because it is getting irritated by the chemoreceptors and mechanoreceptors. But we will silence the cough center so that it won't respond to the afferent stimulus. It won't send a efferent stimulus to the muscles to contract. So no, there is no cough, right? So what all drugs act through this mechanism? We call them as central cough suppressants. So when it comes to the management of cough, that's the fifth thing to learn here, cough management. We can have central cough suppressants. What do? They suppress cough center. Where is it present? It is present in nucleus tractus solitarius. Example, they are mainly the narcotics. So you might have seen many doctors prescribing drugs like codeine, folcodeine, all of that you are studying in your pharmacology, right? Codeine, folcodeine, morphine. Morphine is a very good cough suppressant. They are all narcotics. Obviously, they have the addiction potential. That is why today's time we avoid it. Okay. Then what else I can do if I have to suppress cough? What else I can do? Looking at the receptors. Now, another potential way of suppressing the cough is blocking the receptors for cough, right? This is where the research is heading. So today we are trying to develop drugs which will block TRPV1 or 4 or P2X3. And in fact, Harrison talks about one such drug. And whenever Harrison talks about some drug, there is a potential that it may be asked as an MCQ, right? Before I take you to that drug, I will also tell you about another drug which is considered as centrally acting, but its mechanism of action is not same as the narcotics. Another central cough suppressant is most commonly used. I think all of you have taken it as a lozenge, right? The Tusq and all other branded lozenges we chew when we have sore throat. It is a central cough suppressant called as dextromethorphan. Okay, it is a central cough suppressant, but its mechanism is not directed at the nucleus tractus solitarius, but somewhere else which we do not understand. Another way I can treat cough is I can reduce the sensitivity of the vagus nerve. Means I can make the vagus nerve get activated only when higher level of stimulus is given to it and not at the lower level of stimulus, right? So what is the drug that acts through that mechanism? Harrison mentions about this drug which is called, just give me 1 second guys, I think I have some scrolling issue here. So Harrison mentions here there is a drug called as benzonatate, which acts through inhibition of the neural activity of sensory nerves. When we say sensory nerves, what are we referring? We are referring to the vagus nerve. The sensory nerve for cough reflex is nothing but vagus nerve, right? So we have second class of coughs medications which reduce the decrease sensitivity of sensory neurons in cough reflex. What is the drug we are referring to? Benzonatate. Now for us, the last thing I will be talking today is a drug. I have already told you that we are trying to develop drugs acting through TRPV1, and we have developed one drug which is almost past clinical trials and getting into practice, which is a antagonist of P2X3 channel. We have studied that it is an ATP dependent cough receptor and we can block it. The drug is called as Zepapixant, right? So that is the last point to learn today. That is P2X3 antagonist called as Zepapixant. So these are all the cough suppressant medications we have, but first of all we should know when to suppress, when not to suppress. Ideally when we have productive cough with copious sputum production, especially an underlying causes infection, we should not be suppressing the cough. So these are all cough suppressants, and I want you to specifically understand today that cough suppressant should not be prescribed, in patients with productive cough. So you will study in pharmacology a class of drugs called as expectorants and a class of drugs called as mucolytics, which we can use in such patients, but we should not be using cough suppressants when there is already sputum production, because if you suppress the cough, what will happen to the sputum? It will stay inside your airway, invite more infections and create more troubles. One of the common mistakes that we end up doing as clinicians, we should avoid. So that's it for today guys. I think we have covered briefly what is essential for us to understand cough. So now I hope that next time when you go to bedside to see a patient with complaint of cough, you know what is cough reflex, what is cough, what is its important, what is the meaning of impaired cough, and how to assess cough, right, with respect to duration when we call it as acute, chronic, subacute, and we know what are the major causes for acute, subacute and chronic causes, and how to investigate chronic cough with respect to imaging and when imaging turns out to be normal. And we have a rough idea about the medications which can be used, which are already in practice and which are on the way to come to practice for the cough suppression, right? So with that I am signing off guys today. I will share these notes on the Meded Telegram channel where you can access, and I will also insert the Harrison pages where I have highlighted the key points, which again you can take a quick glance. Most of the key points you need to know from the cough chapter of Harrison is addressed today, and I hope this helps. In the next session we will talk about dyspnea. This is the second important complaint that a patient with respiratory as well as cardiac disorders come to our hospital with. And I'm very sure that when you start going to bedside discussions, when you start getting cases for history taking, you will definitely encounter patients with cough. You will definitely encounter patients who are complaining of shortness of breath or dyspnea. So we'll address these first, then we will take less important symptoms in the subsequent sessions. And I hope these read Harrison along with me is helpful and useful for you guys. And I'm open to your suggestions. If we can make it better by approaching differently, we will be more than happy to do that. Signing off guys, I'll see you. I just lost my mobile connectivity, so I might have missed some of your queries, but I will go through them as soon as I get it charged, and I will definitely address them in the comment section. Looking forward for more participation guys. All the best, study well, let's love Harrison one more time. Thank you.